Hi everyone, welcome to the video lecture on growth and development and tooth eruption. And in this particular chapter, we are going to look at the definition of growth and development. We're going to look at some fundamental principles of growth and development and factors which influence growth and development in general. We are also going to look at some standard milestones of child development, and we're going to outline some of the growth assessment methods that can be used to assess the development of the child. We will also look at the developmental disturbances of the teeth, and we're going to look at how to best classify them in respect of clinical presentation. We will also be looking at some of the differences when you are considering development between child and adult, and of course we will also be looking at the milestones to do that. And finally we'll be looking at eruption of the teeth, and we're going to look at chronology of the teeth and just list out some theories of eruption. Of course we do not have any exact theory to explain the mechanism of erection, but we're going to look at some theories, possible hypotheses. So the lecture is divided into two parts: growth and development per se and eruption of the teeth, and these are the outline of the presentation. In tooth eruption, we are going to look at some of the important aspects of disturbances in tooth eruption, which will be helpful for us to diagnose cases in clinics. So to begin with, let us differentiate between growth and development. Growth on one side is merely increase in mass or size or number of living substance. So when we say a child is growing, that means he's growing in length, that means he's changing in size. And when we say development, we are looking at more complex unidirectional changes in the existence of a single cell or its multifunctional unit. And here we are more looking at complexity in association with growth. So when I say the child is developing normally, that means I'm looking at his mental development, I'm looking at his physical development, and all of this development is in one direction, right? So you can have a child who can develop his IQ, right, but in single direction. So the difference between growth and development, if you understand, it will be easier for us to discuss the topic further. So let's dive in and look at some principles of growth and development. From your lectures on orthodontics, you have looked at these theories of growth of skeletal structures. We are not going to go into further more details of these theories, but I want to highlight something called as functional matrix theory, and this theory explains the development of skeletal growth. When we talk about growth of the long bones, and we talk about growth of the midface, and we talk about growth of the condyles. So I would recommend that you go back to your ortho standard textbooks and try to read about this functional matrix theory, which is given by Melvin Moss, and this explains closest to the development of skeletal tissues. Another thing that we must look at when we're talking about principles of growth and development is that the growth and development of the human body is not a straight line or a linear equation, and we have different parts of the tissues of the body developing at different rates. So I would like your attention to the lymphoid tissues first. So this graph tells us on the y-axis the percentage of growth, and on the x-axis it tells us the age in years. So we have birth and 2 years, 4 years, 6 years, 8, 10, 12 till 20, while we have on the y-axis the percentage of development, that is 0%, 20%, 40%, 60%. So if you look at the curve of the lymphoid tissue, that is your tonsils, it grows very rapidly till the age of about 11 or 12, and only after that the growth of the lymphoid tissues, and I'm giving an example of tonsils where it starts to regress and then come back to its 100%. So the growth in the first 12 years is up to 200%, after which it declines to 100%. in the next 10 years. So similarly, you have for brain and head, where the growth is very steep in the years up till the age 8 and 10, and there it becomes stabilized in a plateau. And for general growth also, you will have some growths happening in the first few years of life till the age of 4. Then there will be a stagnation in the development, and then from 10 to 12 there will be a steep rise in the development, in the growth of the general body, that is your skeletal tissues, and then it will stabilize by the age of 20. And this you can identify much better is your reproductive growth is very slow till the age of 12, and where you have your puberty growth spurt, and this matches with your general growth spurt, and then the development of your sexual organs and puberty, and there's a steep growth till the age of 18 to 20, after which it stabilizes. So you see the growth or the different bodily tissues are different, and this is explained by the differential growth curve. Similarly, we have the growth spurts. So I would like to bring your attention to this graph here. It has on the y-axis the ages in years, and on the y-axis we have the height increase in centimeters per year. So we have taken height as an indicator for growth of skeletal tissues. So if you see here in when you're considering the boys, the blue line, the height generally by the age of 13 starts to increase quite rapidly. Then at 14 it touches, it peaks, and then there is no more increase in the height till the age of 17. And if you compare it with the girls, they achieve their peak height at the age of 12, and therefore there is a difference of 2 years when you talk about the boys and the girls achieving their growth spurts. So if you see, the girls achieve their growth spurts 2 years before the boys do, and this is the reason why you will see that children in the same class, you will find that girls are taller than the boys, even though they are of the same age and they are studying the same class. But as the class progresses, you will find the boys ultimately becoming taller than girls as they reach the age of 17. When the both are 17 years of age, the boys will tend to be taller, because they tend to have growth spurts on an average of 2 years later than the girls. So what factors influence growth and development? So you can generally classify them as into genetic factors and environmental factors, and the list of genetic factors and the environmental factors is given in the slides that you see. And from this you will come to know that certain things like genetic influence and the race influence the growth of a person. So if you have tall parents, you're going to have tall children. And then of course you have maternal factors, considering the mother's DNA, mother's genetic influence on the child. Also you can look at the mother's health during pregnancy, and of course the growth factors which the child's body is facing with the growth hormones and things like that. And on the environmental factors, you will see something like exercises and the nutrition play a very major role in the growth of the child, and illnesses also. Children who fall ill frequently during their childhood tend to have a stunted growth, and they do not achieve their approximate height when they grow older. And similarly, you have these climate and seasonal effects, you have socioeconomic factors and physique and family size and birth order, all influencing growth and development in one way or the other. We are not going to go into the details of all this, as I am presuming that it has been covered in a more detailed lecture in orthodontics for you. So when you talk about stages of growth in children, the growth in children is divided into 4 major portions. The first one is infancy. Infancy is itself divided into 2. Neonate, the children who are born up to the age of 1 month are called as neonates. So child of up to 30 days old is called as a neonate, and the child who is 1 month to 1 year is called as an infant. Okay, so this is a period of infancy. So you will have neonates and infants. Then you have early childhood. The child who is 1 to 3 years old is called as a toddler. Child 3 to 6 years old is called as a preschool children. And then you have middle childhood, and then you have late childhood or young adulthood. So these terms like toddlers and the preschool children and neonates and infancies you must be familiar with, because in our further discussions we are going to refer to them quite often. So, okay, so now we have covered some aspects of growth, and now we're going to look at development. When we look at development, at each age, the child has to show certain developmental milestones, and presence of these developmental milestones at those particular ages will tell us that the development of the child is normal. Now it is very difficult to assess the development of the child in quantitative terms, because there is nothing that we can do to check the development, right? You cannot take x-rays to check the development of the child, so we are relying heavily on our observation of the child. For example, a 2-month old child should normally hold his or her head with support. You see in this picture here, the child cannot hold his head, so the caregiver hand is here, so the child cannot control his head at 2 months of age, and he begins to push up when lying on the tummy, and makes smooth movements with the arms and the legs. Normally you will see the children circling their arms and pedaling their legs. So this is quite normal of a 2 months old child. So as the child grows older, say example 4 months, now he's able to hold his head steady without support. So you see here in this picture, the child is able to lift his head and hold it in position at the age of 4 months. Now at the age of 4 months, if the child is not able to hold his head by himself, then we are looking at some neurological diseases or conditions that we need to investigate. So similarly, I have listed down a few more developmental milestones for children of the age 4 months, and you should be quite familiar with them. You don't need to memorize all of them, but maybe some important points like holds the head and brings the hands to the mouth, right, and holds and shakes toys and swings at dangling toys is all normal of the children. So just try to remember as much milestones as you can. Now for a 6 months old, the child is able to roll over both from the stomach to back and from back to stomach. So this is normal for a 6 months old child, and he begins to sit with support. And at 9 months of age, the child begins to crawl. He sits without support. If you see here, the child is sitting without support, and he moves into sitting position with support. So that means when he's trying to sit, he needs help to help him sit, and he stands holding on to adult or furniture for support, and he pulls things to stand. And this is where children fall down, and they're trying to stand up, and they try to catch hold of the bed sheet of the bed, and they pull the bed sheet in order for them to take support to stand up, and you will see the whole bed sheet uh, coming down on them. And similarly, you have all these furnitures which are kept, and you'll find children in this age are quite susceptible to injuries in this form. They try to pull things in order to stand up, not realizing that those things could be a TV, it could be a computer, it could be a glass of water. So we need to be careful on that. By the age of 1 year, the child moves into the sitting position without support. So you see here, we are constantly following the developmental milestones of sitting, and the child also pulls up to stand and walks alone while holding on to furniture. If you see the baby in this picture here, he tries to take a few steps holding onto the furniture, and then he tries to take a few steps independently, but he cannot walk still. By the age of 18, the child is able to walk alone. By the age of 11 to 18, the child begins to walk alone, and as he grows older, 18 months old, he tries to run and pulls toys while walking, and helps undress himself and drinks from the cup and eats with a spoon. This is where we have to take care not to bottle feed, because if the child is able to drink from a cup is normal and developmental milestones, and he should eat with spoon, and therefore mostly the children in this age should not be bottle fed for their nutritional need. They must come down to drinking milk from the cup and eating their food with the spoon and bowl. Then by the age of 2 years, the children begin to run around and they become very naughty, and they're trying to climb onto things and furnitures without support. And this is the age again where they will fall and hurt themselves in the process of exploring their environment. So again, we need to be very careful of the children in these 2 years of age. And you can also inform the parents that these things are going to happen because their child has turned 2. And this is a very playful stage, and the child tries to discover and explore things around in the environment around him. So those were more on the locomotor developmental milestones, the sitting, the standing, the holding of the head, and more on movement. In this slide we have a speech milestone. So a child who is 1 to 2 months can only say coos, and 2 to 6 months he can laugh and squeal. And as you see, the child gets older and older, right? By the age of 30 to 36 months, that is 3 years of age, he will have almost all speech, and that is the age where the child will begin to communicate. So if you see a child who is 20 months old or about 2 years of old, don't expect him to have conversations with you, because his vocabulary is just more than 50 words, and he can say 2 word sentences at the best. So when you are looking at children, you must look at the speech milestones and then try to communicate in those terms. For example, note used trying to give oral hygiene instructions to a child who is just 1 year old, right? Because only he can communicate is with mama and dada and daddy and bye bye and come, things like that. So you need to be aware of these milestones to help you communicate with children in the clinics. With this, we come down to the actual development of the teeth. And the development of the teeth, as you have already read and learned in your oral histology and dental anatomy, the teeth goes into a number of stages of development, like the bud stage and the cap stage and the early bell and the late bell stage. And all of these stages of tooth development can have anomalies during them. And when a particular anomaly happens in a particular stage, the manifestation is in terms of development anomalies. For example, when you say a tooth bud, okay, that you have this tooth bud stage. Now during the development of the teeth in the tooth bud stage, what happens if you have an extra tooth bud? What will happen if the child has an extra tooth bud during the development stage? This is development anomaly. So you're going to look at supernumerary teeth, right? So if I ask you the cause of a supernumerary tooth, you must tell me, sir, this could be because of an extra tooth bud which developed during the bud stage of development. Okay, so this will help us to reassure the parents of what must have happened during the development of the teeth, what could be the likely causes, so the parents feel reassured that we have the knowledge of why it went wrong and it will not go wrong again. So it's very important for us to have this knowledge. So I recommend that you go back to your textbook on oral pathology and try to look at the developmental disturbances of teeth or dental anomalies in terms of numbers, position, size, shape and structure, and try to correlate them with the developmental stages of teeth, right? For example, if I ask you, say let's have a quiz. Okay, so now in this picture, what can you see? In this picture I see there is a structure which is not supposed to be here, right? So this, we are supposed to have a lateral incisor. This is deciduous lateral incisor with a cingulum, but we do not have a cingulum, we have a projection, and this is called as Talon's cusp. And if I ask you what is the cause of this Talon's cusp, then you must tell me, sir, this is an abnormality in the structure of the tooth, and you must tell me it is arising during which part of tooth development. So let's look at another one. Here you have a child who comes to you with absence of all these teeth. We take a radiograph and we don't find the tooth bud here, so we say these teeth are congenitally absent. So again, you must try to classify the congenital absence of tooth and which part of tooth development has gone wrong. Maybe the bud tooth bud stage has never been initiated for those permanent teeth congenitally for any genetic reason or systemic reasons. So this could be a congenital absence of the teeth, bud, and therefore the teeth. Have a look at this one. Can you see these two teeth here? They kind of fuse together or joined together. Okay, and you see this lateral incisor is nice and big, and this central incisor is nice and big, and this central incisor is joined by two teeth. So again, you must take a radiograph and come to the conclusion that either fusion has happened or gemination has happened. What has actually happened? Then in this picture you will see that the permanent tooth have erupted palatally and the primary teeth have not exfoliated, and this could be a positional developmental anomaly for the permanent tooth. And lastly, we look at the structural defect in the development of teeth, and you see the structure of all the teeth are uniformly show anomaly. So this could be your amelogenesis imperfecta, or it could be your dentinogenesis imperfecta. So what I need you to understand is that correlating the developmental stages to the development anomalies, and that will help you develop your understanding of your clinical presentations, and of course when you're doing counseling to the patients. Now, growth assessment, the physical growth assessment or the skeletal growth assessment can be done in a number of ways that I have listed out for you in the slides here, and some of this is already covered in your lectures on orthodontics, but I want to pull your attention to the dental age of the patient. So when we say what is the dental age of the patient, we are looking at the normal tooth eruption pattern, normal tooth eruption sequence, and from that sequence we say the dental age of the patient is that. That means the dentally the patient is in that particular stage. So if you see that the chronological age is the number of years the child has lived, so chronological age of a child is 8 years, that means he has lived 8 years from his birth. But dental age may not correlate with the dental age. Similarly, like how your skeletal age may be delayed or accelerated, the dental age also can be delayed or accelerated. So the dental age tends to tell us that what sequence of tooth eruption is going on and what are we expecting regarding the eruption of the teeth. So we'll look at this a little later when you talk about chronology of tooth eruption. So you have other also like behavioral age and mental age, and this all helps us to understand, say, the developmental assessment of the child's mental development and his psychomotor development and his motor development and things like that, right? So for us, we just need to know the growth assessment tools and the importance of dental age. So why have we learned all this in the first place, right? As a dentist, you are at a unique place, and the studies have shown that you are among the first healthcare providers to see a child. And when you see a child, it is important for us to recognize any early developmental or growth disturbances so that we can have an early referral for the child, and the child can benefit from an early diagnosis and early interventions. So it is very important for us to realize that. So as a pediatric dentist, or even as a general dentist, you will see children coming to you, and the parent will ask you as a healthcare provider that my child is not able to walk and he's already 18 months old, doctor, do you think there's a problem? Or they may say, doctor, my child doesn't speak any word and he's already 18, is it normal, or what should we do about it? So these kind of questions are going to come your way into dental practice. So you have to get familiar with the developmental milestones, especially with the speech and the skeletal development. So in terms of behavioral pediatrics, the specialists there try to ascertain the developmental and growth of a child using cognitive, motor, language, social, behavioral and adaptive domains, and this itself is a separate subspecialty in pediatrics. So we're not going to go there, but we are just going to pick up a few important things like motor development and language development. And of course behavioral development also is important for us, because we may be looking at children who have hyperactive syndrome or attention seeking syndrome. So those behavioral problems will be there. Children with autism will be there. So again, you must be aware of the normal behavioral development. This brings us to the last part of our presentation, which is on tooth eruption. And when we talk about tooth eruption, it is very important for us to remember that the tooth erupts in stages, and you have this pre-eruptive stage where the tooth is still developing, and this is an example of a premolar developing under a molar. And this pre-eruptive stage goes on and has an intraosseous life, and you see, as the crown is developed and the root starts to develop, there is a resorption of the root of the primary molars, and as the root of the permanent molar further develops, is more resorption of the primary molar till the time that the primary molar gets exfoliated. And when the permanent tooth shows a mucosal penetration is when it is clinically visible. So you can say the tooth is in the stage of mucosal penetration, and from mucosal penetration till it reaches its occlusion, you have your pre-occlusal eruptive stage where the tooth root development is going on and the tooth begins to erupt until it reaches occlusion. After it reaches occlusion, you can have attrition of the occlusal surface, and the tooth further erupts to compensate for that attrition of occlusal surface. So you have something called as post-eruption, tooth eruption, post-occlusal tooth eruption. All right. So these are the stages of tooth eruption. So in this line, I have tried to explain what do we find in pre-eruptive stage, and what do we find in eruptive stage, and what do we find in post-eruptive stage. Pre-eruptive stage is the predecessors, that is the permanent teeth are lingual and they move apically and in their own crypt. For example, most common example is your central incisor. I'm going to show you a picture a little later. And those who do not have a predecessor, that means those teeth which do not have a milk tooth to replace, these tooth have backward extension of the lamina dura. Okay, remember lamina dura, and that is where the tooth bud stage begins. So they have a backward extension of lamina dura. During the post-eruptive stage, like I told you, the tooth tries to adjust to the growing jaws, and there is a compensation for occlusal wear, and there is also a compensation for interproximal wear. And this is very important because when you find that a primary molar which has got mesial caries or a distal caries, or let's say proximal caries, the adjacent tooth will move into the carious area if the tooth is fractured and not treated. Now in this slide, I have tried to present to you how the development of your incisor happens. So this one is your deciduous incisor, and this is your permanent incisor. So it is lingual to the tooth bud, or developing tooth bud of permanent incisor is lingual to the deciduous incisors, and this is how they develop. The deciduous incisors erupt in position, and then the permanent incisors erupt lingually. So similarly, you have for molars, this is how your permanent molars begin to form, and as these primary molars they erupt and take their place in the oral cavity, these permanent crypt slowly starts to shift into the between the roots of the primary molars. So this is how it happens, and of course this picture shows you the developmental stages, and you will realize that there are some milk teeth which are replaced, and then there are some permanent teeth which do not have a milk teeth that they replace. For example, all the permanent molars do not have a milk teeth to replace, while all the premolars and the canines and the incisors have milk teeth to replace. With this, we come to the chronology of human dentition, and when we talk about chronology of human dentition, we are looking at chronology of hard tissue formation. We are looking at the chronology of amount of enamel formed at birth. We're looking at the chronology of enamel completed, eruption, and root completion. In your exams, it is quite frequent for us to ask you chronology of tooth eruption, where we expect you to tell us the ages at which a particular tooth erupts into the oral cavity, and therefore you need to remember the chronology of eruption for deciduous dentition as well as for the permanent dentition. And this chart is very useful and for us to remember the ages so that we do not confuse. This chart is given by Cronfield, and I strongly recommend that you follow this chart when you're trying to remember the dates and what happens. In this table also, I would like to draw your attention that for chronology of eruption and root completion is something that you must know, because these two things will be very commonly asked of you in your clinics, and when you're looking at a case with radiographs, you have to take a call whether to extract or not to extract, or the parents will get a child to you and they will say, doc, my child is already 24 months old and he doesn't have any teeth, is it normal? So to answer that question, you need to remember the chronology of eruption. So when I give you an example of a mother who brings in a 24-month-old child, and she says, doc, that my child is already 2 years of age and he doesn't have any teeth, is it normal? Right? So can you look at this chart and tell me a child who is 24 months old should have how many teeth? Okay, so you see the eruption of second molar is at 24 months, and all these teeth should be erupted by the age of 24. So definitely something is wrong, and we need to investigate and maybe take some radiographs to find out if there is a developing tooth bud inside. So this chart is for deciduous dentition, and this chart is for permanent dentition, and you can see the reference here from Cronfield. That is what we are going to follow. So this is for permanent dentition. So central incisors, eruption, and root completion, and lateral incisors, eruption, tooth completion. So you must remember the date of eruption and the date of their root completion. So with this, we come to a very important part when we are trying to assess the development of teeth, and NOLA has given us 10 stages of tooth development, and when we're looking at a radiograph of a tooth, we can say the tooth is in which stage of development, and from there we can anticipate the mucosal penetration when it's going to happen, and the tooth eruption when it will start. So if you see here in the diagram, the first, or the stage 0, is absence of crypt. After this we have stage 1, which is the presence of crypt, after which we have initial calcification, that is a stage 3, stage 2. Then we have the stage of 1/3 crown completed, then we have 2/3 crown completed, then crown is almost completed, and the crown is completed. After crown completion, 1/3 root development completed, 2/3 root development completed, and stage 9 is almost root completed, and stage 10 is complete root formation. Okay, so the difference between almost root completed and complete root formation is the development of the apical constriction. So teeth which have full root development but do not have apical constriction, if you can see, compare this apical constriction and this apical constriction, this is the difference between the two stages. And this is very important for us to know, especially the 2/3 completion, is for some reason if the pulp undergoes necrosis and we are the tooth development is disturbed and the tooth development basically ceases, so we have to take a decision, look at the radiograph and see the developmental stage of the tooth, and we see there is an open apex, and then we have to treat it accordingly. So we have different protocols like apexogenesis and apexification, which we will look and learn in when we are doing your pediatric endodontics. So this NOLA stages of tooth development is very important in terms of treatment planning, and it is also important for us in terms of estimating the mucosal penetration of the tooth. So the normal consensus is that when the tooth development has reached about 2/3, the tooth will show mucosal penetration, and when the root development is almost complete, the tooth will be in occlusion. So here when a patient asks you, doc, the tooth has not developed, is not erupted, and the child is of such and such age, and you take a radiograph, and on the radiograph you try to assess the tooth is in which stage of tooth development according to the NOLAs, if the tooth is present, of course. And then when you find the tooth is still 1/3 root is completed, so we know that there is still time for the tooth to erupt, because the tooth will erupt only when 3/4 or 2/3 root is completed. So you can give an answer reassuring the parents when approximate age time of tooth eruption. So to complete the discussion here, the tooth erupts 2 millimeters intraosseously, and it takes the tooth 4 to 6 months to do that. Okay, so it takes 4 to 6 months for a tooth to cross 2 millimeters of bone, and with this calculation you can definitely give an approximate date of tooth eruption for parents who are concerned that the teeth of the child or tooth of the child is not erupted. There is another something called as rule of 7, and this rule of 7 says that primary molars, if they are lost before the age of 7, you will have a delayed eruption of the succedaneous premolars, and if the primary molars are lost after the age of 7, the premolars will have accelerated eruption. And the reason I'm telling you this is that you will find that the premolars, which are normally erupt at the age of 11 and 12, you will find that an 8-year-old child is having that premolar, and you are confused why this premolar has erupted before its time, which should be by 10 to 11 years, but I'm seeing this premolar in 9 years old. What has happened? So don't worry, apply the rule of 7, and if the primary molars have been lost after the age of 7, say they were extracted or they have broken down, they were grossly decayed and they have fractured in piecemeal, and the tooth has been lost because of caries, the premolars will show accelerated eruption. So rule of 7 helps us to explain things like that, and also to explain to the parent that if we extract a primary molar before the age of 7, the premolars will have delayed eruption, and therefore it is necessary for us to preserve the space of those extracted primary molars with something called as space maintainers. So I hope you all understand this rule of 7. Last section of the presentation is on the problems during eruption, and we can have a lot of presentation clinical features which will tell us that there is a problem in the eruption mechanism, in the eruption process, and we have listed out some of them here, and we're going to look at some of them in quite detail, so as to because those are very common in there may not be many changes in the gingiva, there may be a slight increase in redness, or there could be a hemorrhage, some bleeding due to the mucosal penetration, and of course increased temperature. And this is the reason, this is the time when the child will try to stick his finger into the mouth, and especially if these fingers are contaminated with any bacteria, they will start to have diarrhea and loose motions and gastrointestinal tract upset, and the child will also have loose motions, and the parents will be wondering how is loose motion associated with the teething. So this is the reason why the child who is having teething may also have diarrhea, and not all children will have diarrhea, depending on the oral hygiene of the parents and the surrounding of the child. So how do we go about teething? Is we do no intervention, we just give analgesics, paracetamol, most safest age appropriate doses, and we can apply topical anesthetic in low doses. Again, there will be some over-the-counter preparations, some herbal medicines that can be applied. There's no harm in applying that, because those medicines are available after they have been tested to be safe for the children. The best thing that you can do apart from analgesic is ask the mother to give child large pieces of cold cucumbers and the carrots, so the child will tend to bite on them, and he will feel ease, especially in the areas where the tooth is erupting. Or you can have commercial teethers which are available, like I have shown in the picture here, and the child will bite on them and he will have relief from the discomfort of teething. So this is what we do about teething. We can also have eruption hematoma. If you see in the picture here, the central incisors are trying to erupt, and during and before the mucosal penetration, when the inflammation is going on, you can have this bleeding which is inside the crypt, and it can present itself as a bluish discoloration. So no need to panic here, it is self-limiting, and as the tooth erupts further, the cyst ruptures and there is no recurrence of this cyst ever again, because it's associated with the eruption. So once the eruption is done, the cyst regresses. The other complication we can have during teething is eruption sequestrum. If you see here in the diagram, you see a bony specule of bone, right? This bony specule of bone will be a barrier to the eruption of this permanent teeth here, right? So this may divert this tooth to have an ectopic eruption, or this could be a barrier to the tooth to eruption fully. It can stop the eruption of the permanent dentition. So we have something called as eruption sequestrum. It is actually a non-viable bone, and this could be because of the remnants of the bone that is broken away from the crypt of the primary teeth, or it could be an odontogenic tissues like an odontoma, or it could be osteomyelitis, part of the osteomyelitis that has happened because the tooth was carious, the primary tooth was carious. So things like this will happen. So if it is symptomatic, you have to excise this tissue, and if it is asymptomatic, you have to observe, so that this developing permanent tooth will gradually push the specule out, and you do not need to do any intervention on that. So your decision making depends on the symptomatic nature of the bony specule, or if the specule is causing a hindrance in the eruption of the permanent tooth. Now this the third part is your ectopic eruption. Ectopic means not in its original or designated space. So ectopic eruption is teeth which are erupting out of their normal space. So here in this picture you see the permanent incisors, mandibular permanent incisors have erupted lingually. If you can remember a few slides before, I have shown the permanent incisors, they develop lingually, and normally when they are erupting they will have a forward growth, and this will cause pressure on the primary incisors, and the primary incisors will show root resorption and they will ultimately exfoliate. So in this case we have ectopic eruption of permanent central incisors. In this particular picture you see, because of lack of space, the permanent canine has ectopically erupted in the buccal vestibule, right? And this is both it's present on both the sides. So we can have local factors of retained tooth or retained root, or you can have arch size, tooth size discrepancy when we have ectopic eruption. So when you are faced with a patient with ectopic eruption, you have to look at orthodontic evaluation of the patient and see what can be done to bring the teeth back into position. Neonatal and natal teeth, again it is not uncommon to have children who are born neonates, so not neonate, children from birth to first month of life, they can have teeth, right? If the teeth are there at birth, it's called as natal teeth, and teeth which erupt within first 30 days are called as neonatal teeth. So presence of these teeth can be normal and it can be distressing, because we have a condition called as the Riga fide disease. Because of the presence of these teeth, the trauma to the ventral surface of the tongue will happen during feeding. So if you remember, during the gum pad stage of development, the tongue has to come forward for suckling of the nipple. The mother's breast, nipple of the mother breast has to have the tongue of the child under it, and there the regular motion of the tongue tries to trickle the milk down the throat. So when the tongue comes forward over the gum pads, it gets traumatized, and you can have a ventral ulcer on the tongue, and this presentation is called as Riga fide disease. So now what do we do about the Riga fide disease? We have to follow a treatment decision tree. So what you need to do is you need to take a radiograph is possible, and if it is a supernumerary teeth, you go in for an extraction. But if it's not a supernumerary teeth, it can be accelerated eruption of the primary incisors. So we have to decide that if it is a permanent primary incisors, does it show severe mobility? If it shows severe mobility, you must go for extraction, because there's always fear of aspiration of the tooth, and difficulty feeding and further laceration of the tongue. But if there's no severe mobility, we have to look at if the patient is presenting with Radiographic disease, and does the mother present with an ulcer on the breast because of the incisors. So if there is Radiographic disease, then you need to maybe maintain with rounding of the edges of the sharp primary incisors. And if the mother does not have any ulceration of the breast because of the teeth, and the child also does not have the Radiographic disease, then all we need to do is just hold the teeth in place and try to maintain oral hygiene and ensure the teeth last till the child grows older to have his full set of primary teeth. So this decision tree is quite helpful when you're trying to deal with the patient with the natal or prenatal teeth or probably Radiographic disease also. So what are the local sensitive factors we can eruption? So local factors I have listed out is ankylosis, delayed eruption, and early exfoliation of primary. So ankylosis can happen when there is a bony union between the tooth roots and the bone, and this can happen because primary teeth are undergoing root resorption. So root resorption is not one process. So the process that is going on when the permanent tooth is developing is root resorption, and there is a gap between the root resorption. So basically what happens that is root resorption is not continuous. So there is a period of root resorption, then there is a period of rest, and then there is a period of root resorption, there is a period of rest. So during this period of rest, if the body tries to compensate for the root resorption by producing osteoblast-like cells, then these osteoblast-like cells will form bone, and then they will try to have cause a bony union of the teeth, of the root to the bone, and therefore you can have an ankylosis. So this ankylosis can be due to traumatic causes, due to metabolic causes, or just purely genetic cause. Now ankylosis is quite common in primary molars. If you see in the picture here, this primary molar has been ankylosed, and therefore it has not erupted to the normal occlusion. And how you will know is when you focus this tooth, you will get a metal sound when you focus, and there will not be a mobility. And of course you need to take a radiograph to confirm the ankylosis. And some of the radiographic features I have listed out for you here is, if you see in the radiograph here, it's a biting radiograph. And this is tooth that has not erupted in the normal occlusion, and this is of course a primary tooth, while these are the premolars. So this premolar is congenitally missing. So if you see here, the break in the continuity of the periodontal ligament is there, and really you cannot make out the periodontal ligament space. So that is how the bony union has happened. So you can do a lot of things with this. Either you can leave the tooth in place after observation, or you can mechanically fixate it in an attempt to cause bleeding and bring back the cells which are going to resorb the roots, or you can just extract the tooth and replace it with prosthetic replacement to have the normal occlusion. Now those were the ankylosis. For delayed eruption, again, delayed eruption in primary teeth can be up to 6 months of the normal chronological date of eruption, and for permanent it can be up to 10 months. So say a mandibular central incisor which is supposed to erupt at the age of 6 to 7 can also erupt at the age of 8, okay, because it's considered to have a normal delay period up to 10 months. So when the parent is asking why my daughter's tooth is not erupted and the tooth is present in the radiograph, the explanation that you must know is that there can be a delayed eruption of up to 10 months in permanent teeth, right? So this is secondary dentition, this is primary dentition, and the causes could be local, systemic, and genetic, and the complications are always crowding, because the adjacent teeth tend to drift into the space which is supposed to be occupied by the unerupted tooth. So of course the treatment is removal of any factors. So if you have a delayed eruption because of a bony specule or sequestrum, or you can of course go in for a full-fledged comprehensive fixed orthodontic treatment to correct that. And you have treatments like gold chain, repositioning of the tooth where you have impacted canines and stuff like that. So of course you're going to read more about that in orthodontics. But to list out some of the local factors that you must investigate when there is a delayed eruption of the tooth is odontoma, supernumerary tooth, space loss, and dental crowding, delay of primary teeth exfoliation, primary teeth, early primary teeth exfoliation. Remember I told you rule of 7. So early primary teeth exfoliation, of course, trauma and dentigerous cyst, again very common. It's very common for us to show you an OPG in your OSCEs which has a dentigerous cyst, and we can ask you to diagnose the case because it will be associated with an unerupted tooth. So you must be quite familiar with at least identifying the local factors in delayed eruption. Then in this slide I have listed out the systemic disorders that can happen: vitamin D, rickets, Gardner syndrome, Down syndrome, cleidocranial dysplasia. And if you're not able to explain the delayed eruption by the local factors, then you must come and investigate on systemic factors, and you will not be surprised that you will come up with some kind of a mild syndrome the child may be having, where appropriate referral to the pediatrician is very important. So some of the reasons for early exfoliation of the teeth is basically trauma. It is very common for the children. Like I told you, the children are quite playful at the age of 2, and then they have a fall and their primary tooth exfoliates, and we never re-implant a primary tooth back. So the tooth is lost, or the child can have an aggressive periodontitis, the teeth will be lost, or maybe the teeth is just extracted or lost due to dental caries. And of course early exfoliation again can have some genetic predilections and some systemic disorders. The genetic and systemic disorder I have just listed out here. You don't need to remember all of it, but you need to remember that there will be some systemic factors responsible for early exfoliation. So if you are again not able to explain early exfoliation from the local factors, then you need to come back and look at the systemic factors and then investigate accordingly. Lastly, we have some theories of tooth eruption. There are plenty of theories of tooth eruption, and we are not able to still say for certainty which theory is exactly working. So in this I have taken this picture from the internet, and very nicely this picture shows all the theories of tooth eruptions. You have coronal follicle, pedial retraction, pulp tissue pressure, root elongation. Then you have pulpal growth, bone growth, pedial tissue pressure, and coiled vessels. Of course, you have learned all this theory in your dental anatomy and histology. So we are not going to go into the details, but here I have listed out the theories for tooth eruption. If you are asked to identify or mention or list any 3, any 4, so you must be able to list out those theories of tooth eruption. To conclude my lecture today, growth and development is a very complex interaction of different processes, so it's not a straightforward process. And if you find disturbance in growth or development of the skeletal or dental, it is always linked to other things also. So we need to have a very suspicious mind with a very broad perspective when we are diagnosing any case of growth and development disorders. And of course, the knowledge about variation and recognition of milestone leads to early diagnosis and hence early intervention for the children. For example, speech therapy is a very common example. A child who's not able to speak and you diagnose the child as having some kind of speech problem, you must refer the child to a speech therapist. And the earlier you do, it's always better for the child, because the child develops the speech, the phonations at particular ages of development. So if the child gets to a speech therapist early, the speech therapist can correct the speech and the child can have a normal speech as in any other child of his age, and the child will not feel left out or need not go to a special school. So it is very important for us to have that knowledge of milestones, especially speech and skeletal. Okay, with this I end this session today, and I would like you all to take 5 minutes just to recollect what we have discussed today. The major topics we looked at: growth and development and eruption. There were the 2 major subheadings in the discussion today, and in growth and development we looked at some fundamentals and some principles, and tooth eruption we looked at the mechanism, we looked at factors influencing tooth eruptions, and that's about it. Okay, and just make a mental note of the headings. This, if you hear this lecture for the first time, you're only going to remember 10-15% of the things that I've spoken, so you need to come back and listen to this lecture again as a revision, or maybe you want to make your own notes. Okay, to end, I would like to refer you to standard textbooks on pediatric dentistry, orthodontics, oral anatomy, and oral histology for more in-depth reading, so that when you enter the clinics, we have more opportunity to discuss any case that comes across, rather than I telling you to go and read those books at that particular time. Okay, so just get a hold of your standard textbooks of pediatric dentistry and orthodontics, should be okay for us. All right, so with this I end my session, and I wish you a very good day, and bye bye.